on. I don't think we have quite everybody yet, but we've got critical mass. So we just started recording. Thanks, Michelle. And Jack, we're ready for you to kick us off whenever.
Okay, great. Well, welcome everyone. Thank you for being with us on this lovely July day. We have a pretty full agenda, but let's do a quick review of that, and then we want to introduce some new folks that are joining us. We're going to do some welcome and how we're going to get updates from our various committees, probably from Sarah and Jeremy, I suspect. We're going to talk a little bit about provider outreach, communications. This is a reflection on our last meeting where a number of us were being asked by various stakeholders about the work and what's underway. And we need to talk about how we respond to that. That's part of this. Then we'll spend some time talking about analyses that we're using to try to inform our growth mitigation strategies, our cost growth, I should say, because we need to know how we're going to find our opportunities for improvement. And I believe Sarah and Michael are going to take us through some of that. We will get a break at 3 o'clock, a 10-minute break. And then we will come back and we will talk about our successor committee. This committee, the implementation committee that we're serving on now, will be coming to an end at some point, probably at the end of the year. And then the question is going to be, well, how do we carry on this work? And what will that committee look like? We want to get some of your feedback about that. And then we will have a public comment time. I think we have one or two folks who want to say something. Sarah, do we know that yet? I know you sent me something about that. Okay. And then we'll try to wrap up and we will absolutely be done by 4 o'clock. We may be finished a little bit early, which will be fine too. So that is the agenda for the day. And hopefully that all makes sense to all of you. Now, we do want to introduce a new committee member, and that is Jason Hawkins. Jason joins us as the Chief Administrative Officer from Peace Harbor Medical Center, which I believe is in Florence, Jason, if I'm not mistaken. So, and Jason is replacing Jen Wielander, who, as you know, left our committee, and she's gone off to do some teaching. And so we will miss Jen. But Jason, we're thrilled to have you. And why don't you take a moment so we can see you and maybe say a few words about yourself, if
Great.
you would.
Yeah, all right, can you all see me on the screen?
We can.
Yeah, well, thank you for letting me join you all, and hopefully I can contribute as soon as I get my feet underneath me after this meeting and get some context of some things. So short background, I've been in Florence for about 4 years now as the Chief Administrative Officer. Been predominantly in the rural space my whole career. I was in Pennsylvania for most of it for the first 25 years, started out in the Geisinger system there and cut my teeth there and learned a lot of great things from a lot of smart people. And then really been kind of in the community hospital, critical access hospital ever since. So been a great fit to come out here in Florence and be part of the Peace Health team. So thank you all for letting me join you.
Well, we're thrilled to have you on our committee, Jason. Thank you for serving. And yeah, I'll tell you, Florence, Oregon is a nice place to be this time of year. So hopefully you're enjoying it.
Yeah, it doesn't break 70 and we still get some misty days. So we're appreciative of nice weather.
Those of us in the Willamette Valley would be happy to get some of that right about now. Okay, well, welcome. The last thing we want to do before I hand it off to our implementation update is to review our May minutes.
Hey, Jack.
Yes, please.
Sorry to interrupt. Can we do either roll call or have all the committee members introduce themselves to Jason?
Oh, yes, of course. Right. All right. Thank you, Sarah. God, my manners are just terrible. Jason, my name is Jack Friedman. I serve as the chair of this great group. I had a history in working in the health plan industry for a number of years and really happy to have you on that. So let's go around and do some introductions. Sarah, do you want to, you have the view of everybody. Why don't you call on folks, will you?
All right, Kevin.
Good afternoon, and really nice to have you added to our group, Jason. I'm Kevin Ewan Shinna. I'm a family physician in Corvallis, and I serve as Chief Medical Officer of Samaritan Health Plans and in Community Health Network, CCO, and I serve as co-chair.
Craig?
Hey, Jason, my name is Craig Anderson. I'm a Senior Vice President and Chief Actuary at Moda Health. And I've been with this company for about 20 years. And previously I worked at Kaiser, and my first job was working for Jack at Providence Health Plan.
Catherine?
Sorry. So welcome, Jason. My name is Catherine Cree. I serve as President and CEO of Legacy Health. We'll have to get together in person sometime. I'm a Geisinger alum as well.
Angela?
Welcome, Jason. Angela Dowling. I'm the president of Regions Blue Cross Blue Shield.
Bill?
Hi, Jason. I'm Bill Ely. I'm Vice President of Actuarial Services for Kaiser Permanente.
Mary Beth?
Hi, I'm Mary Beth Greeno. I'm the healthcare advocate with Osberg.
Felisa?
Hi, I'm Felisa Higgins. I'm the political director at SCIU Local 49.
Brian?
Jason, my name is Brian Kelly, and I'm the CEO of Women's Healthcare Associates, and we serve the Portland metro area.
And do we have William Olson today? I'm not seeing him on the line. Okay, Ken?
Welcome, Jason. I'm Ken Preventure, President and CEO of Pacific Source.
Shannon?
Hi, I'm Shannon Saldivar, owner of an insurance agency in the Columbia River Gorge.
Scott?
Good afternoon, Jason. My name is Scott Schellenberger. I am the CFO for the Corvallis Clinic.
And do we have Jordan today? I'm not seeing him. Oh, okay. And I know Andrew's out. Jesse filling in for him. Do you want to introduce yourself?
Yes. Hi, everyone. I'm Jesse O'Brien. I'm the policy manager with the Division of Financial Regulation at DCBS. I'm here on the behalf of Andrew Stolfi, the insurance commissioner.
Okay, and not available today for vacations or otherwise, Patrick Allen, Jessica Gomez, Andrew Stolfi, John McConnell, William Olson, Mark McMullen, and Jordan Pape. Unless any of you are on the line and I missed you.
Not vacationing together, I don't think, as far as we know, unless they're.
Well, thank you all. Appreciate the introductions and looking forward to working with you all.
All right, thank you very much. Now, has everybody had a chance to look at the May minutes? Are there any questions or concerns? We don't really need a motion here, do we, Sarah? We just want to make sure there's no misinformation in there.
Just any corrections. And I would note that Scott was mistakenly marked not present for the last meeting and he was here, so I will get that updated. Thanks, Scott.
Okay, hearing no other objections, I think we will go ahead and move on. And so I'm going to ask Jeremy and Sarah to please give us an update on the implementation work that's going around, please.
I think I have the first couple of slides, Jeremy, unless you want to say anything to start.
It's all yours, Sarah.
Okay, next slide, please, Michelle. So we've been spending a lot of our energy as a team on the data submission preparation. So the data submission template and guidance for payers to submit the cost growth target annual data file was published on June 30th. All of the mandatory and voluntary reporters who will be submitting this initial data were notified of the guidance and sent a copy of that template. We also published a frequently asked questions document a few days ago. We've been receiving a number of questions from payers that are reviewing the data submission template and guidance, so it's great that everyone's taking a look at that. We anticipate that that FAQ will be updated over the next couple months as we hold both a data submission training that's scheduled on August 4th. All of our mandatory data submitters have been invited to participate in that. We will also record that training and make it available for anyone who can't attend. We also plan on holding 3 office hour sessions over the summer. Those have been scheduled and data submitters have been notified. And that'll just be time for some extra questions, technical troubleshooting as payers prepare that data file. And the data are due October 1st, so that's going to come up pretty fast, but we're feeling like the guidance is in good shape. Next slide, also on the housekeeping side, our temporary rules for the cost growth target program. These are the rules that govern the data submission. Those were filed on June 2nd. Now that they're filed, that gives us 180 days to file the permanent rules. So we already have a draft of those permanent rules that are circulating with our technical advisory group. We'll be holding a rules advisory committee meeting as part of our August technical advisory group meeting on the 25th. And then you can see the rest of the high level timeline for finalizing those permanent rules in October and November. I will say that we're anticipating very minor changes from the temporary rules to the final rules. The only thing that we're really proposing changing is removing the references to this initial data submission that's due October 1st and focusing then on just the annual regular data submission rolling forward. Next, we have also updated and expanded our website a little bit. If any of you have not been on there, there is now some more information. We've built it out a little bit to include a new page for the data submitters that have all of these templates, guidance documents, questions. It'll also include the recordings from the trainings. It includes the rules timeline, all of that. We're also going to start building out some space for the future committee or the successor committee that we'll talk about later today. So some new information on the website if you have not seen it. Next. We also finished up our work with the Health Plan Quality Metrics Committee to select a subset of quality measures for the purposes of cost growth target program monitoring. So as we're working to control costs and meet the cost growth target, we want to be looking at access, quality, and other things to make sure that we're not seeing any problems there. So quality measures that the state will calculate and publish statewide, looking at Medicare, Medicaid, and commercial markets have been selected. We shared an earlier version of this table with you at the May meeting, and I just wanted to call out 2 changes that have been made since that preliminary list. The Health Plan Quality Metrics Committee made one last change since we last talked about this. We originally had proposed using 2 measures borrowed from Washington State that were mental health and substance use treatment reach. So sort of a percentage of the population with a diagnosis who had then received a qualifying service. The Health Plan Quality Metrics Committee expressed some concerns with those measures. So we are going to be modifying the measure from Washington a little bit to address those concerns. That will be the mental health treatment reach measure. And we're going with the HEDIS standard measure initiation and engagement of alcohol and other drug treatment as our substance use measure. So slight change from the table we shared earlier, but otherwise, these are the measures that we'll be using for the cost growth target program. Just as a reminder, there's no benchmark tied to this measure. This is just for broader context and understanding what's happening with quality in the state in conjunction with looking at costs. And we are working, our team is working on a baseline measure report of these measures, looking at 2018, 19, and 20 data. We're coordinating with the CCO metrics team on that because some of these are metrics that they regularly publish on the Medicaid side, and we are hoping to move that forward this fall. Lisa.
Can these measures be disaggregated by race?
Yes and no. So yes, in that they are administratively based measures and they can be disaggregated by race and other demographic variables. We are producing them out of the all payer all claims data, which has incomplete race ethnicity data across all markets. So we are working on some supplemental approaches to that until the data are more robust. So it is possible that some of these will be able to be disaggregated, but since the data are not complete, it's not a guarantee. Michael.
I'm wondering, Sarah, just to follow up on Felisa's question, whether you might be able to do it for the Medicaid data, where I'm guessing you probably have more complete data than you do for commercial and Medicare?
We do have more complete race and ethnicity data for Medicaid than we do for commercial and Medicare, but there are also some challenges with that data. So the All Payer, All Claims database program and the team have been working on some fixes to that, and we're hoping to have more robust reporting in the future, but it's not perfect. Okay, Jeremy.
So the Value-Based Payment Compact work group is officially off the ground now. They had their first meeting on the 30th. There's 3 at-large seats that haven't been filled yet. The group talked about what types of expertise would be helpful. The good discussion around the need to really start this work with it being centered in equity. And so talked about both trying to find some experts who have that expertise as well as outside of just members of the group, pulling in other expertise around equity. I'm also looking for some more expertise around safety net, primary care, some more geographic diversity, children with special needs, and integrated systems. So quite a few things to try to put into 3 seats, but we're out doing some recruitment to try to fill those out. And I expect, like I said, there may be some need to get expertise in other ways other than members. We're on a fairly fast timeline. Folks will be, now that the group is officially launched, will be meeting monthly. The first task is to come up with a roadmap that will really map out implementation of advanced value-based payment models, and then to also come up later in the year with a list of barriers that need to be addressed in order to be able to accelerate adoption. There was a good amount of discussion, which we'll talk about later today, around the need for communication and trying to be talking to providers about how the value-based payment work fits within 889 and the differences and the connection there. So I think the work that we'll be doing later today on communications, I think information will be helpful to take back to the value-based payment work group. I want to go to the next slide. Sorry, I was on the wrong screen here. So the other thing I just wanted to touch on was some other major themes coming out of the legislative session, one of which has to do with our work directly, but otherwise just wanted to give kind of an overview of session. I know a lot of folks are tracking it very closely. Overall, would say there was an enormous theme around health equity. The session, some really significant investments in behavioral health and funding the Medicaid program and maintaining coverage there. But there was also, and I'd say this is directly connected to equity, a focus on the need for continuing to expand coverage as well as affordability and cost containment as we try to as key strategies for getting to health equity. On the coverage side, there's quite a few moving parts that I think do fit together, but I have to kind of explain it a bit. There's going to be really a big push over the next couple of years, I see, for really getting to universal coverage, insurance coverage as a state. We're at 94% pre-pandemic. I think all accounts are that, the most the state could probably get up to is probably about 98%. Massachusetts has the highest rate of insurance, and they're at 97%, just for context. And there's several pieces of this, some coming out of the session and some things that were in motion ahead of time. We're working on our 1115 Medicaid waiver renewal. And part of that, we're looking to figure out how to have a more soft landing for the folks who came onto the Oregon Health Plan during the pandemic and may go off once we start doing eligibility redeterminations, and making sure that we don't lose those folks and that we can keep them either enrolled in Medicaid or the marketplace, wherever the right place is. But also looking at some strategies around reducing churn and making it easier for folks who are eligible for a Medicaid to be able to get more easily enrolled and stay enrolled and keep families together. So we're looking at a variety of strategies there. The legislature is moving they passed a bill to move the marketplace from DCBS over to OHA, and that's both, I'd say, sort of a cost containment and universal coverage strategy ideas to bring the marketplace closer to our other purchasing strategies, so we can keep things like value-based payment and quality and things of that nature better aligned. But we'll also be thinking about some strategies for improving enrollment in the marketplace. We know a lot of folks who are uninsured are actually eligible for subsidies, but they aren't enrolling, and so need to look at some ways to improve enrollment there. The legislature also invested about $100 million to expand coverage for low-income adults who are ineligible for Medicaid now, for a variety of reasons. The largest being immigration status. The program's called Cover All People, and was a first in the country expansion, and will fill in a major gap from the Affordable Care Act. So we're sort of weaving these things together. I guess the other one is legislature also asked us to bring back a plan for developing a public option. And I really see this as trying to develop a more affordable commercial insurance product for folks who are still struggling with costs. So we're launching a team internally that's going to be managing all these moving parts, and collectively see these as a set of strategies to really get us to 98% insurance coverage over the next several years. A key piece of that is also affordability. And so obviously our work on cost containment is just that much more important. The legislature passed the accountability mechanism, House Bill 2081, with broad bipartisan support. And I already mentioned public option. Part of the public option is also having us design a pilot for a regional multi-payer global budget model. That's due next summer, and the idea is to create a path for multiple lines of business to come together under a global budget in a region of the state. And the legislature also passed a mergers and acquisitions review bill, which we have under cost containment here, but it actually has a much broader view of really understanding what consolidation does to cost and quality and equity more generally. So quite a bit of work ahead of us this session. And just wanted to give a quick update there. I think back to you, Jack.
Okay, are there any comments or questions for Jeremy or for Sarah on our various implementation committees? I do have one, and so I'll start. I can't see everybody, Sarah, so if you see someone, please let me know. Jeremy, I'm curious to know, what do you think the specific outcome will be of the VBP subcommittee? To be honest, it feels to me like it's been watered down a little bit. At one point, I thought that we were going to have very specific recommendations on 3 to 5 different risk models that might count as true value-based. But I'm hearing that there's not a big appetite for being that prescriptive. Can you give me your thoughts on what you hope will come out of that work that will move the market to more VB?
Yeah, thanks, Jack, and would welcome Ken and Kevin or others to weigh in as well. So the group first has to do a roadmap over the next couple of months, and that roadmap is basically mapping out the path to getting to these targets that we've established in the compact over the next several years. Once they develop the roadmap, then they'll move into identifying what barriers are in the way of getting to adoption and recommendations for breaking those down. So I would imagine, I'm just throwing this out there, but it's something that's come up in this group, is a potential barrier could be folks who don't have a primary care provider and needing to figure out how to address that with health plans that don't require, the plan design doesn't require a primary care provider. I think that's an issue that has been raised several times now as a potential challenge to moving towards more total cost of care payment models. So I would expect those types of things will be raised. The group will report out twice a year to OHA and the Health Policy Board, as well as all the folks who signed the compact, the senior leaders of those organizations, on progress, on barriers, on recommendations. They'll also be revisiting at some point over the next couple of years whether the targets are achievable or not. There was I think, Jack, where you're really hitting at is the group going to come up with the actual models themselves? And we had some discussion early on I think there were some strong opinions, especially on the provider side, of not being to the spot yet as a state where we could sort of come up with just a few models and dictate exactly what those models are. That there needed to be some more flexibility. I think I share a concern of not, as we move into value-based payment, not making the system even more complicated than it already is with a whole bunch of new payment models. I also think that, and I think Michael, others may be able to speak to this more than I can. I also don't know that we're there as a state to be able to say it's these specific payment models, and it may look very different from region to region, and depending on the provider or payer's size. So the group did not, when we mapped out the charter, did not want to be that specific, but I think if that becomes a barrier to adoption, I'm sure there's something that they could bring back. But right now they're not slated to actually design the models themselves. They're more focused on what are the challenges that will get in the way to adoption.
Okay.
And Jack, I'll just add too that the first meeting was really a level set meeting. We have many people that have been added to this new committee that really haven't been aware of the work that we've done here on 889 Implementation Committee. And if you ask people that were participating on that group what their definition of value-based payment all is, it's very, very different dependent on whether you're a clinician, a hospital, or a payer. So the first meeting was really coming together to understand the work that's been done thus far, doing a level set, and then moving forward.
Right. And Kevin, is the LAN model, the LAN, learning model that we reviewed, that I think the CCOs adopted some of that thinking, is that a framework that people are referring to as a kind of way to progress through this world?
My perspective is it's important to keep that same framework only because of the work that we've been doing here on this implementation committee. The specifics of the LAN model haven't really been discussed at that first meeting of value-based payment, but my sense is that we want to be aligned as much as possible.
Although the targets are based on the LAN framework. And Jack, I stressed Jeremy's point. I think Jeremy did a nice job as well in summarizing things. But I think the notion of having, 2 or 3 or whatever models has been mentioned from time to time. I don't think we ever had agreement that was going to be part of the work.
Yeah. Okay. Yeah. No, that's fair. Okay. Very good. Thank you both. Thank you all. Any other comments or questions on this part of the agenda before we move to responding to providers? I don't see anything. Okay, so we're good to go, Sarah? Yeah? All right. So if we could get the next slide.
Actually, Jack, can I back up? I should have meant to say 2 other things that are kind of implementation updates. One, wanted to just share that I think the Oregon Health Policy Board, which now has 2 new members, including Jessica Gomez from this committee and Bill Kramer, who folks may know has been a longtime health policy expert in the state. They're really eager to get the first cost trends hearing off the ground later this year, recognizing it won't be with the data from the likely won't be with the first batch of data from that measuring actual cost growth, but having some forum to bring folks together and kind of do a dry run of how we'll do this, how we'll bring stakeholders together, the types of conversations that we could have. I think there is a big opportunity, I think, given the pandemic, and thinking about the comments from Hospital Association today, I think there probably is a space to do this even without the hard cost growth target data, just to be able to start to bring folks together and sort of do a dry run, if you will, of how this will work. So I just wanted to share, I think we're going to start planning with the board for some type of forum later this year where we can start to bring together some information around cost challenges folks are having and have a discussion like we will in future years around challenges and opportunities around cost. Secondly, I just wanted to share, I'm not sure where to put it in the agenda, but I'm hearing a lot of anecdotal information from folks around price increases that they're seeing in the market this year. We've been seeing it within public employee programs. I've talked to 2 or 3 insurers this week who said they're feeling the pressure of 15 to 20% price increases coming out of the pandemic. I think it's a challenge. You know, we have a longer accountability implementation timeline for this group over the next 5 years. But I think it's something that folks are going to be watching really closely, and we knew that there's going to be some disruption coming out of the pandemic. But I think legislators, I think others are going to be closely watching that, and I'm not sure if everybody's feeling the same, but certainly we're starting to see some data that's pointing that direction. Some potentially some big price increases this year.
When you talk about price increases, just to be clear, you're talking about the provider rate increases on the commercial side?
That's right. Yep.
Boy, 15 to 20%, that's not a number I've heard, but I'm not in that world anymore. I don't know if any providers on the committee want to respond to it, but
yeah, and I'm not saying that's what it'll shake out to be. I'm just hearing
Yeah.
folks saying as they're entering contract negotiations, that's been some starting places with some providers.
Okay. Wow. Well, that's not going to make it very easy for us to hit our 3.4%. I can tell you that.
Well,
That's pretty good.
I'll just jump in here, having we just finished, we're just finishing up rounds of negotiation on our Taft-Hartley and some other places. And we are seeing huge cost increases coming across the board for us. Things that we haven't seen since the Affordable Care Act, in that 10 to 15% increases on premium rates was what people are asking for. And so our pushback has had to be very aggressive on that. And I will say that if you're in the commercial market right now and you don't know about the work that's happening here, it's pretty concerning, because I assume if we're saying in 3 different plans between 10 and 15% requests, I assume that's what the rest of the commercial market is also seeing.
And that's a premium increase, you're saying, for Felicia, which could be a combination of both price increase and
right.
utilization. Yeah.
Yeah, and I will say, we can look at our utilization. It's a Taft-Hartley, and I will say our utilization, like the rest of the state's utilization, has been in the toilet, frankly, because you couldn't really utilize healthcare for a variety of time during COVID. And so folks weren't utilizing it. So if you take out the utilization component, what you really have left is cost. And we've had no major cases, frankly, that I would say have driven utilization. So we haven't had any 10% of our unit, of our 2,000 members, didn't get cancer all of a sudden.
Oh, right. Yeah. Okay. Well, we could unpack a lot there, and we don't have the time, but that's an interesting observation. So thank you for sharing that. Are there any other comments before we move to the next topic on this? Any questions for Sarah or Jeremy on the various implementation efforts that are going on? No. Okay. All right. You recall that the last time that we met, there was some discussion about how committee members could generally respond to questions from providers who were not that aware of the cost growth target work. There was a request to try to help us as committee members prepare ourselves so that we could answer that in a good way. So given that, I'm going to ask Jeremy, and maybe Sarah as well, I'm not sure, but Jeremy, I think you're going to lead us in some dialogue about efforts underway to outreach to providers who may not be in the know on this. So take it away.
Thanks, Jack. And I'll turn it over to Sarah here in just a second, but why don't we go to the next slide? So we've talked about this at the last couple of meetings, the need for more outreach and communication. And I've certainly heard from a number of folks that, if folks have heard anything, they've maybe heard about the cost per target, or they've heard about the value-based payment, maybe not about both. And there's some confusion around what the two are. So we, at our last meeting, we also shared our sort of tentative list of organizations that possibly could be held accountable under the cost growth targets. We've kind of got that list. It's a broader net than likely what organizations actually could be held accountable, but was sort of our first cut at it. And you all asked for some guidance around some materials, some stock decks and materials that would be helpful. And Sarah's been working on some of that. Next slide. Just a reminder that, you know, I really think about this program as an annual cycle, starting in the upper right. You know, first we're going to measure whether or not we met the target broadly, and then we'll identify organizations that were above or below the target. And for those that were above, we'll have conversations with them. We'll do more analysis to understand why. We'll also do a broad set of analysis statewide on what the trends are in the market overall and what potential cost drivers are, and then we'll have a report. But then we'll go into the public hearing and really the policy conversation of what are the levers we can pull as a state to try to get costs under control, and then we'll rinse and repeat. So we're sort of in that cycle right now. As I mentioned, this fall, we're planning to do the sort of first run at some type of cost trends hearing, although it won't be with the same data. I think it'd be more of a convening and discussion and less about did we meet the target or not specifically. So I think it's a good time right now for us to start doing that outreach. And need to do it in several ways. We need to both identify organizations that could be held accountable so they know, but also want to be creating just more awareness of state policy goal of meeting the target, as well as awareness around the efforts around value-based payment. So we're trying to blend sort of all of those things together in our strategy for outreach. And as Sarah will walk through, we've kind of got several layers for how we propose doing it. So Sarah, when I turn over to you.
So what we are about to walk through is our proposal for provider outreach. So I'm going to cover purpose, content, who, and a little bit about the timing. I think this is a proposal that we really are looking for your feedback on. So especially those of you who are providers, how will this land? How can we make this better? Who are we missing? Are these the right messages? So after I go through all of this, the next couple of slides, we'll really just be looking for your reactions and any ways we can improve this plan. So I think, as Jeremy and Jack both said, our purpose for this provider outreach is to, it's multifold. We want to spread awareness of the cost growth target program, both that it exists and also how it works. So some of that annual cycle, who it applies to, what we're going to be doing, what the point of all of this is. Also want to provide that clarity about the cost growth target and the related efforts. We know there's confusion about the cost growth target and the value-based payment compact targets. We've also heard that there might be some confusion about Senate Bill 770, which is the Universal Healthcare Task Force. And we want to make sure that that's clear as well. And we want to use this as an opportunity to start engaging provider organizations in strategies to help mitigate cost growth. So that could be, hey, your organization hasn't signed the VBP compact yet. Would you like to do that? Here's how to get involved. It could be identifying other strategies. We know that as a committee, you've talked before about not wanting any single strategy to be sort of the one mandated, one true direction that everyone has to comply with, but rather that there's lots of flexibility for each organization to identify their own strategies or to identify best practices and share with others and take their own steps towards cost containment. So we're really hoping that this is an opportunity to connect with provider organizations in that way and to potentially identify some champions and others who can help carry the message. Next. So we want to provide a lot of information, and this might be too much information for one session. This might end up needing to be several different materials packets. I think one note that came through in the public comment from the Hospital Association that I shared out this morning was a reflection that multiple touches might be needed, that just a one and done presentation might not be sufficient. And I think thinking about all the content that we might want provider organizations to be aware of, that seems very true to me. So we want to be talking about the purpose of the program. We want to be talking about that annual program cycle. We want to provide some information on which provider organizations are included. We know there's a lot of confusion out there about who this applies to. And that includes, does this apply to me as an individual provider, as well as is my organization large enough, and is my organization the type of organization to be included? We talked a lot last year early on about specialty versus primary care and those different inclusion criteria for providers. So all of that is part of this conversation. We want to talk about the data and how provider organization performance is measured and validated, especially important because the data are coming from the payers. And so we'll anticipate once the data are validated with the payers, there will need to be a validation process with the providers as well. And the cost growth target data, we anticipate based on experience in other states, it's not always the same as what a provider might have seen. So they might have received a report on total cost of care from their contracted payer, and these data might be different, and we want to be able to understand that and let them know that there are plans to work through that. We want to talk about the process to understand the provider organization cost growth, some of those reasonable reasons that we've talked about previously, how the accountability mechanisms work and when they kick in, especially because there's that fairly long ramp up period, especially before any of the financial penalties would apply. I want to talk about the implementation timeline, provider organization responsibilities. And let me stop here. This was a question that came in and we've included it in our new frequently asked questions document. Some provider organizations are asking if they have to submit data. And we want to be really clear that provider organizations don't submit data for this program. Payers are the data submitters, and that is the requirement. We also want to be clear that there's not, this is a little tricky to say, we also want to be clear there's not a requirement that providers or payers meet the cost growth target. That's certainly the hope, that's the intention, but there's nothing sort of in statute or in the program that says you must meet the cost growth target or else. Granted, there are accountability mechanisms and you can interpret those as the or else, but there's some confusion about what does this mean for me in terms of contracting, or what does this mean for me in terms of being a provider in Oregon. And so we want to try to provide some more clarity about that. As I said before, the suggested actions for provider organizations, and then how to find more information and get involved. So as I said before, that's a lot to cover. We've been spending, more than a year on all of this, not necessarily expecting to go deep on all of this with every single provider organization. Some folks might be more familiar than others. Some folks might need something really focused, but this is the broad content that we think we'd be trying to cover. Next, again, content, there's also a very large audience. So we are suggesting breaking it out into 2 phases. And we would focus first on the phase 1 audience, and that would be those large health systems and the provider organizations that we think are likely to be included in the cost growth target based on size. So Jeremy mentioned that we had previously developed that preliminary list using our all payer all claims data to identify organizations that we think might be large enough, might meet those thresholds for inclusion. And that would be our starting place for that phase 1 list. We know, again, it's not going to be that exact list, because the true list will be based on the payer submitted data, and we're not really going to get our hands into that until it comes in October, but this will give us a starting place to start the messaging. In phase 2, we would focus on smaller provider organizations, solo practitioners, and specialty practices. So those who are not directly accountable or likely to be included, but might be interested, the work might be related or relevant, and we'd be looking to connect with those providers on a longer timeline. Next. So in terms of our strategies, we want to crosswalk the list of potential provider organizations for that phase 1 audience with these strategies to make sure that there's a plan to reach everybody. And as I've said, we likely need multiple repetitions, so not just one strategy, one audience, and done. We really want to use this as an opportunity to coordinate with professional organizations and other partners. I think there's some really great opportunities to plug in to provide webinars, presentations. There are a number of annual professional and association meetings coming up this fall that we think might be good opportunities to tap into. We also have a lot of OHA programs and channels to reach providers. So the patient-centered primary care home maintains provider communications, and that's something we can tap into. And there are a number of other programs internally that we can leverage. We want to create some tools for partners and for you as committee members that you can use to help carry the message. If you end up having conversations with providers or having opportunities to cover some of this, we want to make sure that you feel prepared and that you have materials that you can use. So that'll be maybe the canned slide deck or some canned handouts that can be modified or that can be used as a starting point for those conversations. And then finally, we anticipate that all of us will be having one-on-one conversations with providers. So that might be folks who call you, folks who call us. That might be just chance, unplanned encounters and conversations that come up. But we think this will be part of it. Not everything will necessarily be a formal presentation. So some combination of all of the above to reach all of that, at least phase 1 audience to start. And finally, on the next slide, just a little bit about what we're thinking for timing. So we're in Q3 now, which is wild to think already. So in August, we will start working on developing materials, identifying some co-presenters, which might be any number of you committee members, and then getting on schedules, especially for those upcoming meetings, professional organization meetings that we know are coming up. We'll push out the talking points and communication materials to you to use, and we'll start connecting with that phase 1 audience. Before the end of the year, we think those phase 1 outreach opportunities will continue. We'll also continue to update our materials, like our frequently asked questions, and make that available to payers and providers. That initial public hearing, our cost trends hearing that Jeremy mentioned, we hope to have by the end of the year. Maybe we'll see how scheduling shakes out. There could be some flexibility in that. That'll definitely be another opportunity for provider outreach and engagement. And then starting next year, next calendar year, we'll continue with phase 1, and then we'll start working with phase 2. We'll also more specifically follow up with the phase 1 organizations once we have a better sense of the provider organizations who will be included in the cost growth target program once we have that initial data and have the official list. So a little bit more refinement coming next year. And I'll stop there. I just talked a whole lot. So I think let me pause and see if you have any feedback on our provider outreach strategy.
Sarah, this is Jack. Are we getting any help on this? Maybe Kevin can answer this, from the OMA or from the Association of Hospitals. I thought they were generally working with us on this, and it would be nice since they are the 2 big representatives of providers in our state.
We have not officially reached out to the OMA or to the Hospital Association yet. You are the first group looking at this proposal. I know Kevin's about to weigh in, but I will say again, the Hospital Association reviewed this proposal and provided some comment this morning, and they are supportive, and we're hoping to partner with them.
Yeah, good.
And I'll just speak on behalf of OMA. We have had discussions on the how to get this message across to providers within the state of Oregon. And I just want to ensure the group here is also aware that part of that clinician discussion from either large clinics or hospitals that employ clinicians will have to be a discussion of the current payment mechanism that comes from CMS and with CPT codes, et cetera, the RVRBS system is really a fee-for-service methodology payment to clinicians. And what we're talking about here with alternate payment methodologies is very different from that mechanics of how clinicians get paid today. So it's going to be a nuanced conversation with how clinicians kind of stay engaged with both worlds for a while, submitting codes for the services that they do day in, day out, but also the payment that may come to those clinicians in a value-based payment methodology. So it's really important to understand that while we're having the discussions of how to change the environment to a value-based payment here in Oregon, the mechanics of how clinicians get paid nationally has not changed. It's still all fee-for-service RVRBS.
Yeah. Very good. Great comment, Kevin. Thank you. Other thoughts here? Do people feel that we're covering the right topics? Do you like the process, the phased approach? How do people feel about this approach to educating our providers on our work? It looks like Craig has a comment.
Yeah, I have some feedback, but Sarah, I think before I get into that, I have a question. I mean, what have you heard from providers in terms of the questions they have about the program? Is this modeled around initial feedback or that sort of thing?
Yeah, Michelle, can you go back to that content slide with the long list of bullet points? That content slide is based on the questions we've had. And we're not We haven't updated an FAQ that's specifically for providers yet, but I think the biggest questions coming up are, does this apply to me? What data are you using? What do I have to do? What am I responsible for? And then this confusion about the target. There's the cost growth target, and then there's the value-based payment compact targets, and what those mean and who's responsible for what. And if I meet the cost growth target, but not the VBP compact target, is that a problem, and vice versa? So there's just a lot of swirl in that area.
Yeah, so I guess my feedback is a comment like, who does this apply to? I think that's a little bit nuanced, meaning it applies to those that are measured, but it really applies to everybody. I think that needs to be mentioned as an aside. And so there's that. And then the other thing is the target, the 3.4% target. I think we need to be careful that that's not immediately translated into that's a unit cost increase target, which again is something to be careful of. And then the last thing I think I would mention is kind of in line with what Kevin was saying. I feel like there's an opportunity to sell value-based payment methodology. So it doesn't feel like it's a takeaway. This is strictly a cap, but we are also combining this with value-based payments, which has an upside and a lot of advantages as well. So it seems like if you're able to get that across, that would be helpful. That's all I have.
Thank you, that's helpful. Brian?
Let's see. Yeah, I do a little bit more about the non-measured. When I think about the medical groups, they are going to need to be engaged around this because, you know, the health plans will be coming and integrated health systems will be coming to them more than likely. So the other group I was thinking about is Oregon Medical Group Management Association. Many of those smaller groups belong to that. So I can't criticize because obviously it's most important to get to those groups that are going to be measured, but most independent practices aren't part of those larger groups that are going to be measured. So yeah, it's just strategizing on how to get to them because I'll say those other organizations will be talking to them. So they need information so they can digest and be prepared for those conversations.
Thanks. And if I can comment on that, I think what you're mentioning is why we're hoping all of the committee members can help with this in various ways, and why we hope to give you some materials that you can use and go out so that Jeremy and I aren't trying to essentially talk to every provider in the state between the two of us. We really want to have you all help connect, and if you see those opportunities to help provide the message, we really would like you to be part of that.
Very good. Other comments or questions? Okay. Sarah, anybody I'm missing?
Not seeing any hands. Michelle, can you go to the next slide? I realized I totally skipped over something that I should mention. That one, thank you. Additional outreach. Yep. Okay. So when we were starting to draft this provider strategy, we got some good feedback, I think from Michael and from some other folks who were saying, okay, providers are all well and good, but what about the rest of your outreach strategy? So I just want to note and reflect that, yes, we need some additional outreach strategies, and that likely includes employer and industry associations, the PEB and OEB boards, insurance brokers, and consumer advocates. And we do need to work on this a little bit more and have some more deliberate strategies to connect in these other areas, not just provider organizations. Some of these groups we're already connected with. Some of the conversations have been ongoing. Some of them will take a little bit more deliberate outreach, but we just wanted to mention that we have not forgotten this part of the work. It just hasn't felt quite as urgent as the provider questions and provider outreach.
Good. Yeah, great. All right, well, I don't see any other comments, so thank you, Sarah and Jeremy, and we appreciate the effort, and please let any of us know how we can advance the thinking here, and if you need any of us to participate in these efforts. All right? Great. All right. We're going to change topics now and ask Michael to lead us. I think Michael and Sarah both are going to kind of lead us through their thinking on how we go about identifying drivers of cost so that we can develop strategies to mitigate that. That takes some work. And here to present the thinking behind that are Michael, who you all know, Michael Baylett, and Sarah. Michael, take it away.
Thank you, Jack. So I'm the warm-up act, and then Sarah's going to be the main show. So
that's the story of my life, Michael. Story of my life. You just said that.
So I want to give a little context. Can we go to the next slide? Actually, 2 slides. No, 3 slides, actually. There, no, 1 back. Thank you. All right, so you saw this slide earlier. This was referred to earlier as the annual program cycle, but this is really a graphic depiction of the logic model and the activities that circle around the cost growth target. As a reminder, the cost growth target is means, not an end, right? It's a tool, and we're supplementing that tool with a bunch of activities. Over the last 2 meetings, we spent a lot of time around that blue circle, identify, and we talked about processes and criteria for prioritizing and adopting strategies. And I'm going to give you a little refresher on what we talked about. So I'm going to give you that refresher first and remind you what you all decided upon. And then we're going to go backwards in the process, and we're going to focus on that orange circle of analyze, because it's the analysis of data to understand what's driving trend and what's driving overall spending that's going to inform your identification and the future advisory body's identification of opportunities to slow cost growth. It's not the only source of information to identify strategies, but it's a really important one. All right, so I'm going to focus on identify, and then Sarah's going to talk about some early activities around analyze. Next slide, please. So we talked last couple of meetings about reviewing data, but coupling that with payer and provider organization experience, maybe research literature from elsewhere, stakeholder input to identify policy opportunities to slow healthcare spending growth and improve affordability. Next slide. During the May meeting, during the March meeting, and then again during the May meeting, we proposed a process and criteria for prioritizing and adopting strategies. These were the 3 steps that we talked about. All right. I want to note that you approved the process at the last meeting in May. You requested a number of modifications be made after looking at a revised draft, and those modifications were integrated into a final document. Next slide. So things we want to cover today. 1, review the approved process and criteria document that went out with you with the meeting materials from Sarah that you received. I'm going to highlight some of the changes that we made to that process for identifying priority strategies and the criteria by which they would be evaluated. And then 2, we want to talk about some planned analyses, initial analyses to identify cost drivers in preparation for you reviewing some preliminary data in September. So that's that orange analysis circle that we talked about. And then we're going to seek your input, your advice on how to focus future analyses. There are some initial ones that are planned, but we're going to be seeking your input on how to really target some analyses. We haven't talked about this topic for a really long time. In fact, a number of you weren't even on the implementation committee when we talked about the data use strategy. So if you don't remember it, that's fine. But when we talked about it initially, it was at a somewhat conceptual level. We're at a brass tacks level right now because we're moving towards action. Just as a reminder that when I use the term data use strategy, or when Sarah does, we're really talking about an analytic plan to inform cost mitigating action. That's what we mean by data use strategy. All right, so before we go there, I just want to review some of the changes that we made to the document that outlines the process for prioritizing strategies to address cost drivers and the criteria to decide which ones merit prioritization. Next slide, please. So first, we added a clarification that committee strategy recommendations will not limit independent actions taken by payers and providers, and I would say, or by the state. So while this is a process to raise up some strategies as a priority, it's understood that other actors may act unilaterally where they see opportunity to do so. Two, we noted that while the overall thrust is to slow spending growth, there may be public priority to increase spending in certain areas. Behavioral health is identified here as an example. I'll note an example from another state. Connecticut simultaneously is implementing a cost growth target that over a few years brings them down to a 2.9% growth rate, but they also have a primary care spend target to double primary care spending investment. So what's that saying? It's saying that while spending is coming down, they also are looking for a redistribution of spending growth, because the only way you're going to get to 2.9% and double primary care is by significantly slowing spending growth in other areas. All right, so it's possible that there might be a state priority to increase spending in some targeted areas, even while overall spending growth is going to be slowed relative to historical trend. Three, and this is all in response to feedback that you had at the last meeting. We noted that it should not be the case that strategies with long-term impact, but no short-term impact should be ruled out. So something doesn't have to have a 2-year ROI, which is so often the case for so many cost slowing strategies. If you all review a strategy and you think it's going to have significant long-term impact, and it's going to take a while to see that impact, but it's worth the investment of time and resources, then you are not prohibited from prioritizing such a strategy based on our criteria. Four, we clarified that any strategy assessment process will separately look at implementation timelines and impact timelines. Relates a little bit to the prior one. And then five, we removed a 5% threshold for savings. Some of you said, hey, it might be that a few different strategies that generate 1% savings is worth pursuing, and we shouldn't just look for individual strategies that are going to have a larger impact. So this allows for smaller savings strategies. Hopefully some of this sounds familiar, but let me pause and invite your reactions, any questions you might have. Again, you have the narrative document that incorporates these changes. I think this reflects 2 meetings worth of conversations. And we're not this process and set of criteria, but as you begin to review data analyses, and as you begin to out time to identify potential strategies, you're probably not that long off from beginning to use this process and the criteria. Okay, next slide, please. So I'm going to transition now to Sarah talking about the data use strategy. This is, again, the design and execution of analyses to identify strategies to mitigate healthcare spending growth. OHA has been planning its data use strategy for some time, including which analyses to prioritize for development and implementation. Some of the work that you're going to see has been informed by recommendations that were published by the Peterson-Milbank program for the 5 cost growth target states that are participating in the program. Today, Sarah is going to share some initial planned analyses for your feedback, and I encourage you to give it some thoughtful reflection in your input.
Thanks, Michael. And I want to make sure Michael and his team get credit. He said some of this is informed by those recommendations from Peterson-Milbank, and I would say that this is heavily informed by a memo that Michael and his team wrote for the Peterson-Milbank states. And we'll talk a little bit more about what we've based this on. But full credit, Michael. We could not have put this together without that starting place. So from that Peterson-Milbank memo on the next slide, the team, the recommendation for states pursuing a data use strategy for their cost growth target is to think about this in 2 major types of analysis. So we've got phase 1 and phase 2. And today we're really focusing on the phase 1 analysis and reporting. So phase 1 would be standard reports that are produced on an annual basis. And this essentially becomes our canned reports. And so we would report on performance relative to the cost growth target and all of these phase 1 reports that would help us understand why performance is what it is. This would help us inform, track, and monitor the impact of the cost growth target. This would be supplemented by phase 2 reports, which are more in-depth ad hoc reports where we do deep dives as needed. And we don't quite know what those will be yet because we don't know where we need to do those deep dives, but they will be based off of those phase 1 standard reports. And the link to the memo that a lot of this came from is on that slide if anyone's curious and wants to take a closer look. But in that memo, there is a proposed analytic framework to guide the construction of analyses to inform the efforts to slow healthcare cost growth. And that's organized around 3 major questions. Where is spending problematic? What is causing the problem? And who is accountable? So looking at things like high spending, where is spending growing? Where are we seeing variation in spending? How do our spending trends compare to other spending trends? Are the spending trends based on price, volume, intensity, population characteristics, or something else? And are we seeing this statewide? Are we seeing variation by market, Medicaid, Medicare, commercial? What does this look like? And then at the more granular payer and provider organization levels. So lots of dimensions here for this analytic framework, but these 3 key questions or these 3 buckets are guiding the proposed analyses. Next. So that the memo, the Peterson-Milbank program is recommending that states begin with 11 standard analyses that would be produced annually. These analyses should examine the effects of price, volume, service intensity, and population characteristics in the context of the broader change to understand spending and spending growth. We would use at least 2 years worth of data, if not more, to understand trend. They would be produced on a total and per capita spending basis. And I would maybe put a little asterisk in there, per capita and PMPM or PMPY, a couple different ways to look at things there. And that they would be released at the same time as our performance relative to the cost growth target report. So next slide. We spent a good chunk of time over the last couple months with our team reviewing these proposed standard analyses and thinking about our internal capacity, what we've already built, what we already can report on, where we can leverage some of that, and where some of these analyses will take more time and effort to implement. Some are going to take some additional development, some we've already done, some are really close to being done. So I'm going to walk you through the short list of those 11 standard recommended reports and what we think we can do and where we are in producing them. So this is our plan for an initial report. We think we'll be able to implement these in the next, I don't know, half a year. Some of these are the preliminary data that we want to bring to you at the September meeting to talk about. Others will come a little bit later, maybe for that initial first public hearing or first cost trends forum that Jeremy mentioned, and still others might be a little bit later as part of a full annual report. We're really focusing our initial reporting, so everything I'm going to talk about is really looking at 2018, 19, and 20. So this will help us understand trends prior to our first cost growth target measurement year, which is 2021, and will help us understand the impact of COVID-19. So the first standard report that we intend to produce as part of our data use strategy is looking at the spend and trend by market. So this is a high-level analysis of spending and spending growth at commercial, Medicare, and Medicaid markets. This is similar to, but not exactly, what we'll be reporting as performance relative to cost growth. The official performance relative to cost growth and the accountability is all based on that payer data submitted file. What we're talking about here is using our all payer claims database and looking at some of the underlying trends and drill down. This is going to be different just because we have self-insured data in one place and not the other. Completeness of claims and timing will be a little bit different. So this is not going to be identical to the payer submitted data, but we think and we hope certainly that it should be similar trends. We should see the same direction. And as we drill down, we'll have a better understanding of what's happening in the spend and trend. So is this, is it price? Is it utilization? Is it something else? This is a report we already have in progress. We have a 2018 and 19 report in development, and this is some of the preliminary data we are hoping to bring to you in September. Should I go through all of them or should I stop for questions on each one? What's most helpful, Jack?
I think you should go through all of them, and then let's get the full picture and people can come back and respond, okay?
Great. So then the second thing that we would add to this is looking at the spend and trend by geography. So one of the questions that the memo had suggested was each state needs to figure out what geography they want to report on. Some of the examples that we looked at were city-based, others were county-based. Our team thinks it makes the most sense to do county-based reporting for Oregon because we can then combine the counties into larger regions, and that'll give us a couple of options in rolling it up. We can roll up to align with CCO regions, we can roll up to align with the commercial insurance rating regions, and other, as you all know, there's many different regions, many different ways to slice the regions in Oregon, and so reporting out by county will give us some flexibility. This is, again, just that spend and trend, same, but then stratified by geography. The 2018 and 19 data are in progress, and we're hoping to have preliminary data for you in September. Next, we would have the spend and trend by service category. So this would be looking at defined service categories and subcategories. We would also stratify this by market. So for example, inpatient commercial versus inpatient Medicare versus inpatient Medicaid. One of the questions for cost growth target states to think about is which service categories they want to use. There are many different ways to bundle this, and one of the things that we have already operationalized is the service categories that are used by the Healthcare Cost Institute for their annual report. So we have those service categories and subcategories already developed with a little bit of customization for Oregon. And we have a report in progress that will actually be 2013 to 2018 spend and trend. So we'll be able to understand what's happening by category and whether or not what is happening in these categories is price or utilization based. So multiple drill down possible in this analysis. Next, we have spend and trend by demographics. So this is looking at how trends are differing among communities with different demographic characteristics. There are a number of options here depending on what demographic data is available. We are planning on using our all payer claims database. And as we mentioned earlier, in response to Felicia's comment, the race ethnicity data in APAC are incomplete. So what we are proposing starting with is age and sex. We have both of those fields in APAC, and we can slice the spend and trend in those ways to start with. Our APAC team is also working on some projects to pull in supplemental data like census data, American Community Survey data, so that we have more robust demographic data that can be applied and used for analysis. It's not the same as individual level demographic data, but we do have some options here that we're working on, and we're trying to see how much of that is viable so that we can add some more demographic variables to the list. As I mentioned in the implementation updates, we are planning on reporting baseline performance on those selected quality measures that the Health Plan Quality Metrics Committee helped pick for us. So again, that baseline analysis is in progress, and we're hoping to have some results for you not in September, but sometime later this year or early next year. And then finally, we have negative impacts. So as part of our quality and equity work, we talked a lot about that. These would be selected indicators to help monitor for potential negative impacts of the cost growth target. These are a lot of different data sources. There's a lot of options here, but we're really starting to coalesce in two major categories. The first category is looking at the healthcare workforce. So let's understand what's happening with salary, wages, hours, FTE, and we have a couple of different data sources that we're exploring there. And then consumer costs. So that's things like premiums, deductibles, out-of-pocket spending, as well as some of the measures that we looked at from the Oregon Health Insurance Survey at our last meeting, thinking about percentage of folks who had to delay care. Things like that would also be in this category. And we're looking at compiling that together into a baseline report. This is going to be probably the broadest level where most of the data sources we're looking at are only available at the state level. We won't have a lot of granularity necessarily at the market level or the provider payer level like we do for the claims-based analysis, but we are continuing to see what we can do. There might be some geographic or other demographic drill down that can happen for the negative impacts monitoring, but this is something we're working on. So on the next slide, just to summarize all of what I talked through, this is what we're thinking would be in the annual report at some point in the future when we have regular annual reporting, and at what level the analysis would be. So statewide, at the market level, or at the payer provider level. We'd have performance relative to the cost growth target. So how are we doing? We'd have the accountability mechanisms. So that would be how many organizations or payers or providers were put on a performance improvement plan, for example. And then we'd have the spend and trend and all the different ways to look at that at the statewide and the market level. And next slide, this is all work that's specific to the cost growth target program, but we also have a lot of related reporting that's underway that provides really important context to what we're talking about creating in these standard analyses. So a couple of reports that I wanted to mention. We have our annual Senate Bill 900 hospital prices reporting. So that's the average commercial price for common inpatient and outpatient hospital procedures. That dashboard actually just came out last week, I think. So there's annual commercial hospital data there. We have a hospital price comparison report that we're working on, hopefully coming out in August. There's the annual value-based payment report. There's the annual prescription drug spending report that DCBS puts out that we want to stay really closely connected to. We have the primary care spending report, that legislative program that looks at percent of dollars going to primary care, and a new report that will be coming. The first report is due in 2026, and this is coming out of the Mergers and Acquisitions Bill, and this is a report on the state of healthcare consolidation in Oregon. So this is definitely something that we expect will be a factor that we'll see as we understand cost growth and cost growth drivers, and we wanted to put it on the list, even though it's a few years out. There's also a lot more I haven't listed here. We have hospital utilization and financials, hospital community benefit. We know there's a lot of interest in behavioral health, thinking about behavioral health spend measurement. There's other quality reporting. There's a lot of reporting out there, and we don't, it can be overwhelming. So we want to think about what's most helpful and what we pull into those standard reports. So in our September meeting, as I've mentioned, we're hoping to bring some of the preliminary analyses to you for discussion. We really see this as a first opportunity to explore the data and identify opportunities. This could be a really juicy policy meeting. This could also help set us up for that initial public hearing. So thinking about if any of these analyses are going to be helpful for that cost trends hearing, and or based on these analyses, what questions do you have? Who would you want to hear from? If you remember back, maybe not all of the committee members, but some of you might remember back when we showed the video and shared the clip from the Massachusetts cost growth target hearing where they had the pharmacy panel and they were asking questions of the pharmacy folks. So thinking about looking at some of this data, what kind of panels might we want to pull together in Oregon? And what else would you want to know? And some of those questions we'll be able to incorporate into these phase 1 standard reports. Some will be more appropriate for that public hearing, back and forth conversation, and some of it might inform that phase 2 deep dive analysis that we're not sure where we want to go yet. So let me stop there and see if you have any questions or reactions.
Okay, thank you, Sarah. A couple of actuaries who are used to this kind of work on our committee, and both of them actually have very engaging personalities. So do either of you have any comments about this? Kevin, I see your hand up and I'll get to you in a minute. Craig or Bill, does this, you know, sort of jive with the world you live in? Does this seem right?
Yeah, I mean, I think it does jive with the world that I live in. You know, having said that, I had, you know, some questions as well around some of the, yeah, probably too in the weeds, but some generic ones around geography. You know, geography of who? The provider, the member and where they live,
Member.
or
The
the
member.
location of the attributed provider for that member.
Nope, the member.
So, I mean, in that, maybe you somewhat answered that by the roll up. That gets a little bit of apples and oranges when you start to focus on individual counties versus member lives versus where they access their care, be it through work or some other mechanism. But in general, on target, I can't remember, and maybe I never knew, but I would be interested on the HCCI service categories, on how much detail that is, and maybe more importantly, how does that relate to the type of service categories others on this committee are looking at, you know, looking at every day. So can we ultimately bridge our data and our insights with what those categories are from the HCCI?
I would be happy to share the HCCI categories and subcategories that we've adopted out with the committee.
Good. Yeah, that would be useful, I think. Thank you, Bill. Kevin, I see your hands up, and Craig, if you have a comment as well, that'd be helpful. Let's go to Kevin and then Ken, and then we'll see who else pops up.
Great. Question regarding the annual report we get on prescription drug spending, and great to see that from a high level perspective, but I don't know the answer, and maybe you do. How much can we drill down further into that annual prescription drug spending report? And I see prescription drug spending as good spending. An example is statin use in diabetics. That's a good spend for prescriptions. But a questionable spend is aducanumab for Alzheimer's disease. So how can we use this prescription drug spending report to potentially drill down and further see what is a good prescription spend to help guide us versus questionable?
Yeah, and Jesse, if you're still on the line, I'm going to put you on the spot in a second, but I want to use this as an example. Thank you, Kevin, because I think it's a really perfect case of where we have multiple things that we're pulling together. So the DCBS high cost prescription drug report has specific things, but also the spend and trend by service category. One of the service categories is pharmacy, and it has many subcategories under that. And so looking at those two things together, there's quite a bit of drill down possible. And then we might have some supplemental reports. I could imagine that a number of states are going to be interested in tracking, I can never say it right, aducanumab spending as its own thing, just because we know it's going to be such an impact on this. So that could be an example of one of those supplemental reports where we track something specifically. So it's sort of all of these things in conjunction. But Jesse, if you're still on, do you want to comment on the prescription drug report?
Yeah, hi everyone. This is Jesse O'Brien with DCBS. There may be some pieces to this that are very specific, but you know, related to the information that we get out of our drug price transparency program, you know, we get reports for drugs that meet a certain price increase threshold, or that are introduced at a certain price as a new specialty drug. And we get some information about the reason why the price was set at that level or increased by that amount. And you know, it is definitely, you can drill down to the individual drug level, but you know, we don't get those reports for all drugs. We get them for drugs that meet those thresholds. And one thing that came out of the legislative session that will be part of this work going forward is a new prescription drug affordability board, which was set up by Senate Bill 844. And we are in the process of kind of scoping out that project. It's going to be at DCBS, and there's going to be a board appointed by the governor and confirmed by the Senate, and there'll be a staff at DCBS, and it will annually do a deeper dive into a smaller subset of drugs that the board determines to have a significant cost impact on the system. And I think that will include looking at not just the price, but the kind of overall total cost impact. And Kevin, like you were saying, there certainly are some drugs that help bring down the overall cost, where the costs are less concerning. But we would want to look at drugs where the prices seem unreasonable given the benefit. But this is something that's really in its infancy. We do have a lot of reports, a few years now of reporting under the Drug Price Transparency Program. And actually, we're in the process of standing up our public-facing website, where there'll be a lot of information about the reports that we get. Happy to answer questions about any of that. I'm not sure if that provided answers to any of the questions that the committee has.
Thanks, Jesse. Michael?
Yeah, I have a real life example of drill down analysis in Rhode Island on pharmacy spend. So 2017 to 2018 trend, which was their baseline period. They discovered that pharmacy was a major contributor to trend for both the commercial and Medicaid markets. And so they did drill down analysis in their APCD. They distinguished retail pharmacy from medical pharmacy, which is really infusion drugs, and were able to isolate the dramatic growth of spending in infusion drugs, and also found out that infusion drugs show up in professional claims and inpatient hospital claims and outpatient hospital claims all over the place. And then for retail pharmacy, they were able to look at different drug classes and break down where was the spend growing. They distinguished generics from brand name, and really got a much finer sense of what was contributing to pharmacy spend growth. I would think that when you begin to get your annual cost growth target performance data in, you too will find areas where spending growth is fastest, and you want to drill down there. Connecticut's doing this right now for hospital spending, because all their growth is in hospital spending. And so they're doing a supplemental analysis that's looking at, is it price, intensity, or utilization, both inpatient and outpatient? They are breaking it down by hospital. They're looking at it by hospital type, hospital affiliation, to get a better sense of what are the factors that are driving hospital spending growth in Connecticut.
Ken, you have a comment, please?
Yeah, it's sort of a question for Sarah. Sarah, good stuff, by the way, well put together. I was thinking when Bill was asking his question, kind of on subtleties sitting behind some of the data and some of the nuances. I'm not too worried about Bill and Craig being able to look at multiple sources of data and kind of interpret all the differences. But I do have this sort of cynical bias that people are pretty good at finding data to support their biases. And as we have these multiple sources of truth, that problem sort of exacerbates. Have you thought about how to manage that at all, or how we help people get this broader view of the data?
I don't think I have a definitive answer. I think this is part of what we're hoping that you as a committee and your successor committee help in prioritizing and saying, here's what we're going to lift out as the major drivers or the major things to focus on. I think I would also note that the policy board will play a role in that. The public hearing will have a role in that, in deciding sort of what we prioritize, what we focus on in a given year, because we can't look at everything. Even though I would say one of our foundational values is transparency, and we want all this data to be available. And of course, that means people can look at any of it and pick and choose what they want. But I think you as a committee will play a role. I think we want the policy board to play a role in helping prioritize. Jeremy, would you add anything to that?
No, I mean, I can agree with you, Ken. I mean, I think there's just a lot of data out there and you can get overwhelmed. And then there's also data we have and data we don't. And, you know, I think it's easy to say, here's the problem because it's based on the data we have, even though there might be gaps. But I generally agree. I mean, I think a key like we felt like a key role of the successor committee to this group is going to be that ongoing advice of where should we focus, where should we be doing our analysis.
Scott, it looks like you have a comment, please.
So it's nice to be able to look back at the data from the prior years. And maybe my CPA brain is working too fast, but clearly I think what may have been driving factors in 2018, 19, and 20 will not be what's driving factors, I'm going to say, post-COVID. I mean, for instance, we're looking at 6 to 8% market increases right now, you know, just for staffing. We've historically seen 6 to 9% increases in our drug cost in 2018, 19, and 20. And talking to some of our GPOs, we're going to probably see them significantly more. So is there some kind of cross comparison for assumptions between, you know, this 18, 19 data and 21 and 22? Because I mean, it's kind of a pretty significant change between the last 5 years. Does that question make sense?
Totally. Let me reflect back. I think we see this initial reporting as serving a couple of purposes. We want to provide as much historic information as possible. For one, transparency. For two, getting everyone familiar with what the system looked like before COVID and the impact of COVID so that we understand what actually has changed when we look at current. And I think this is going to be a key role for you as a committee and the successor committee in deciding where to focus. It might be that we look at this historic data and we say this would really stood out in the historic data, and you all can say from your current experience, but this is not a problem now. This has resolved itself. We should prioritize elsewhere. And I think that's where we'll be looking to the committee for some advice on what's important. We will never have the perfect real-time data. So I wouldn't necessarily anticipate that we set up this as a baseline and then we benchmark everything back to it. I think this is to help understand the historic context and also to give us practice going through the data validation, the reviewing it and prioritizing it and discussing it as a committee and as a community. We have to get good at knowing what to look at and how to talk about it as well.
Yeah, good comment. Are there anybody else on the panel, on the committee rather, that has had some experience in trying to understand utilization and healthcare cost data? Any observations or insights that you'd want to share? Does this approach seem to make sense to all of you, knowing it's going to be refined? Yeah. Oh, Craig, thanks. Yeah, please.
Yeah, so I think the approach makes sense. It's consistent with how health plans look at this data. And I did look at the Milbank resources, which are really helpful and detailed. So that I think that makes sense. I think the part I'm having a little bit of trouble, well, not trouble, but just things maybe to consider. One is the delay, which Scott mentioned just a moment ago. And I think we need to keep in mind, ultimately, we're looking at these accountable entities to be managing the growth cost curve for the growth. And they should be receiving, if this all works out, they'll all be under value-based payment arrangements with payers, and they'll be accountable for total cost of care. And they'll be receiving reports from payers in more real time. So I think that's ultimately our goal. I think this sort of analysis is sort of market wide. I don't see it as meaningful for a specific provider's performance. I think they have to get that from the payers and then somehow accumulate that because of working with multiple payers. Yeah, thanks. And then the things we identify, we just want to make sure it doesn't conflict with what we're ultimately trying to do with value-based payments. So that's one thing we run into is I think the more at risk we put providers, the less they want us to be putting additional constraints, because we have I guess a bargain in the sense that they're managing costs without a lot of intervention. There's just ultimate accountability for total cost of care.
Craig, thank you for that. I think that's really important, and I didn't say that. These are not intended to be actionable reports for providers. They're probably not intended to be actionable reports for payers, although they might help payers decide where to go look internally. That provider level reporting and the payer-provider communication is a totally separate conversation. I think in a lot of ways, the audience here is you as the committee and you as policy makers, and thinking about based on this and based on this, what it can tell us with limitations. What does this tell us for broad strategies? We've already focused on VBP as one strategy. Are there other major directions we should go in? It's not the very granular, my clinic should do X. This will not meet that need.
Yeah, thanks.
Yeah, that's a great point. Other comments, thoughts? Sarah, is this what what else were you hoping to get here?
This is great. As always, if people want to think about this a little bit more and email any questions or comments, it's really helpful for us in planning. We have some of these reports in progress and underway, and we'll talk more about it in September. So I think this will be another opportunity to continue to iterate on what it means to be looking at this data.
Yeah.
But I'm not hearing any major concerns with the analyses that we've proposed.
No, I'm not hearing that. Catherine or Angela, Mary Beth, folks, we haven't heard from any comments, any thoughts before we move off this topic? Oh, Craig, your hand is still up. Do you want to say something else?
Well, I have one more comment question actually for Sarah. Who's going to do the analysis to present to the committee?
Our team, the cost growth target team, we have dedicated analysts who work on cost growth target reporting, and they are embedded with our all payer claims analysts.
Great, thank you.
Jack and Sarah, I don't have any other comments.
Okay, very good. Okay, guys. I think that might be a wrap on this topic. So thank you for this, and I'm sure there'll be more to come. Sarah, are we at break time now?
Yeah, we're about 20 minutes ahead of schedule, but we are at break time.
We are. Okay, so folks, I have about 2:40. So why don't we do this? Why don't we take a 15-minute break, give people a chance to kind of catch up. And if we could be back on the call at 2:55, that would be wonderful. And we will get started on the second part of our agenda. I do think we'll be able to get you out of here before 4. Is that fair? Okay. Thank you. All right, I hope everybody had a nice break. All right, so our next topic is to talk about a kind of successor committee and what that might look like going into 2022, what the purpose of that group will be, and how we might go about putting the committee together. So with that, I guess I'm going to ask Jeremy and Sarah if you would kind of take the implementation committee kind of through your thinking on this, and kind of what you might want from us in response. Okay.
Thanks, Jack. Let me just tee it up and turn it back over to Sarah. So folks may recall that this committee, which was established just in Senate Bill 889, sunsets in statute at the end of the year. But the committee agreed, you all have agreed to continue a committee like this on under the Health Policy Board. This group was originally by statute selected by the governor. Once that statute goes away, the policy board will be the one that will select membership and do the charter for the group like they do with their other committees. So we want to lay out a proposal for you today on membership and charter, so we can begin to start to do recruitment. Even though it feels like we just had this conversation with you all, like feels like yesterday about sticking around for another year. We're already halfway through the year, and so January is going to sneak up on us pretty quick. Here's the overall timeline. This group's been around since the fall of 2019, but as I mentioned, we'll sunset in December, and then want to launch the new committee. Certainly invite anybody from this group who is interested in continuing on. This isn't a means of trying to kick you all out and start a new group, but also recognize that folks have been on for several years, and you may have other commitments, or might make more sense that there's some different folks around the table, or maybe we'll end up with sort of a blend. I will say that the policy board is very, very focused on diversity of voices around its committees, and I expect that will be a very robust conversation with the board as we're getting into recruitment. So let me pass it off to Sarah.
Thanks. Okay, so our proposal is, after this committee, you all sunset in December, we will establish a new committee. We are tentatively calling that the Cost Growth Target Advisory Committee, open to feedback on that name. This would become a committee of the Oregon Health Policy Board, and we would launch starting January 2022. So in the materials packet for today, we have a draft charter that has a lot of detail in it. I'm going to lift a couple things out of that charter, but just know you have that in the packet. I'm looking today for your feedback on the proposed charge for this new committee, the proposed membership, and the proposed recruitment plan. So I'm going to talk about the charge and the membership first, and then stop for some discussion, and then talk about the recruitment plan and have discussion about that separately. So for the proposed charge, and a lot of these things hopefully look familiar because they're things that you are doing, or they're things that you recommended previously as part of the recommendations report that the future committee should be responsible for. So number one would be reviewing and understanding the cost growth trends and cost growth drivers. So that's things like looking at the data and surfacing all of those contextual factors like we were just talking about before the break. It would be identifying and addressing opportunities to reduce cost growth. So those strategies, the mitigation strategies, identifying and prioritizing new work. This would also include reviewing and understanding how we're doing and our progress towards VBP goals and how the VBP compact is working. The group would explore opportunities to improve equity, monitor for negative impacts of the cost growth target, provide some oversight for ongoing program implementation, inform public hearings, and revisit the cost growth target for 2026 to 2030. So remember, when you initially set the cost growth target, you had an asterisk that said a group should reconvene and look at the updated data and all of the economic indicators and see if the recommendation to drop the cost growth target to 3.0% in 2026 is the right one, or if that needs revision. So that would be an explicit charge of the new committee. As Jeremy said, this would be specifically a committee of the Health Policy Board. And so the Policy Board, OHA, or DCBS may change the Advisory Board committee responsibilities over time as things pop up, as other policies emerge. There might be some additions to this, but this is the starting charge that we see for the committee. Next, let's talk a little bit about membership. So in terms of structure of the membership, we're thinking that advisory committee members would serve 2-year terms. We might stagger that a little bit so that not everybody just rolls off immediately and we have a brand new committee in 2 years. We would want some continuity, so terms could be extended. as Jeremy said, the new committee would be appointed by the policy board rather than by the governor, and that would go through an open recruitment process and in line with the policy board committee diversification work, which I'll talk about later. And the members would need to fulfill the responsibilities as described in the charter. So similar to how you all committed to participating and fulfilling those responsibilities, we would look for the successor committee to do the same. In terms of who the members might be, so if you think about our committee, I want to pause on this just for a second because it's been causing us some consternation internally. When we look at Senate Bill 889 and the different seats that are this committee currently, there's some specific positions. So the director of DCBS or delegate, so that's Andrew, or today that's Jesse. And then there was sort of a placeholder that said at least 13 members that represented the following. And there was a list of industries and perspectives and experience that should be brought. When the governor appointed you all, it was not in a 1 person to 1 seat ratio. You all bring different experience, you have different hats, and you've been able to share those multiple perspectives. So when we think about the proposed membership for the committee, I just want to put that same caveat out to you for this next slide, that we're not necessarily thinking that each of these bulleted points or each of these seats is 1 person. It might be multiple people might represent multiple perspectives, and that's okay. So with that said, on the next slide is our proposed membership. So similar to what we have today, we would want both industry and non-industry representatives. So on the industry side, healthcare payers, representatives of large hospitals and health systems, as well as representatives of smaller and independent providers. On the non-industry side, we would want employers, purchasers, and consumer advocates. We would continue to have our ex officio members, so the OHA director, the DCBS director, and the state economist, or any of their designees. And then some specific expertise that we think we would be looking for, expertise in healthcare financing, healthcare administration, health economics, and integrating equity into policy. This is new. This is not something that's currently in our list of expertise, but given the charge that we have and all of the monitoring for negative impacts and work to incorporate equity into our work moving forward, we think this is important expertise to add to the advisory committee. So this, as I said, this might be multiple people, some of the same people. We are not yet recommending what the right number of committee members is. And I think that might be something for your feedback or discussion today. Right now, there are 20 members. That's a lot. Not all board committees are that large. There are some larger. So I think looking for your feedback on is this the right mix of representation, and how many people do you think we might want to be aiming for to ensure that we have this balance. So I'm going to stop there and see if you have any questions about the proposed charge, questions or feedback about the proposed charge or the proposed membership.
Okay. Comments, folks? Don't all speak at once.
Angela.
Angela, please. Good. Let's
I
go
was
with
just going to
Angela.
say,
Mary
I know
Beth.
you're concerned about the number, but if you're going to have this type of representation, I don't see how you can narrow the scope. I think that's probably right. In fact, it might be just slightly larger because you'll have to have some diverse opinions and perspectives on it.
Yeah.
So I echo your concerns. I just don't think it can be small. I just don't see how it could be smaller on that.
That's a good point. Yeah, thank you. Mary Beth, thoughts?
Yeah, I was just curious as to, in terms of the smaller and independent providers, since many of them aren't being necessarily counted in the cost growth target, what the kind of rationale for having them in the advisory committee would be.
Yeah, great question. I think this is maybe a spectrum question. So I think we've got sort of the larger systems. We have, the legacy system, the Providence system. Then we have the too small to be included providers that might be, Dr. Bartleman's clinic. But then there's the in the middle place, and there are a number of practices that are large enough to be included, but not one of the larger systems. And so I think Brian and Scott both represent some of those currently.
Right.
Perfect.
Good.
Just wanted to
Yep.
clarify that.
Great. Kevin, comment.
Yeah, I'm not surprised by the charge or the membership. It looks like it's in line with what we as a implementation committee have wanted to see. And I would hope to just a supporting principle of the new membership is reflective of that urban versus rural divide and ensuring we're really looking at participation from throughout the state.
Yeah, that's a great comment. Thank you, Kevin. Scott, your hand's up.
All right, well, I actually had two. Mary Beth had one of my two. When I look at the expertise, when we talk about healthcare financing, is that like banking? Well, I mean, I guess I have several different things that go through my brain, so I'll tease out maybe what you mean by financing.
I would love some more feedback on this. So healthcare financing is one of the current expertise for you all as a collective body. And so I pulled that language directly from the original statute, but I think it might not be as precise as what we're thinking, which is really understanding the cost drivers. That's it's that side of financing. And I don't know how we should best describe that as expertise.
All right.
Maybe actuarial. Is that, I don't know how, Scott, if that makes sense. Actuarial science.
Yeah, that definitively helps. I was thinking that, Jack, but then there was also part of me that says, is there room for, a GPO? We call it GPO, group purchasing organization, and they're not really financing, but they are definitely involved in, I'll use the word materials cost.
Yeah.
So space hasn't defined. I may add more comments as we go along. So that's helpful in clarifying. Thank you.
Mm-hmm. Good. Okay. I see Ken has his hand up.
Sarah, I wonder if maybe under both industry and non-industry, if it makes sense to have some sort of at-large category. I think if somebody like Shannon, who I guess probably qualifies as a consumer advocate, but is sort of industry, not sort of, is industry, and yet doesn't fall into one of those neat categories. So just gives you a little bit of flexibility to look at some folks that might bring some interesting perspectives. We're not saying, and you could do that in a way that doesn't require that we have anybody from all those categories, but just gives you a little bit of flexibility.
Great point. Thank you.
Other comments? I think, Sarah, this for me makes a lot of sense. I think the real, maybe one of the elephants in the room here might be something, since I'll take that on, since I'm kind of retired, so what the heck. But I think this committee has been in the design work, but we haven't necessarily been in the monitoring of performance work. And my only question is, can we have stakeholders on the new committee, the advisory committee, who are also players in the industry that are being, monitored for their allegiance and commitment to the target? And I just think that's a question we have to ask. We're going to need stakeholders, and hopefully people that are on the committee and are also actors in the industry can do both. Is that your thinking?
Yeah, and thanks for bringing this up, Jack. I think maybe this should be added to the charge because it's not part of the charge. And we should be really clear
Oh,
that
good. Yes.
the advisory committee is not responsible for holding payers and providers accountable. The advisory committee is not the one making the decision about whether a PIP or a financial penalty is applied. That authority rests with the state and possibly with the policy board, but not with the committee. And so I don't think we perceive a conflict of interest.
That's excellent.
And I think the implementation committee has been incredibly successful because of such strong representation to date.
Yeah, that's very helpful. Thank you very much. All right, other thoughts, comments on the proposed direction of the advisory committee? All right. Sarah, what is the timing on this? When would you expect the state to begin to solicit folks? And if people on the implementation committee are interested in further serving, is there a way they could do that? What's your thinking there?
Thanks for that segue. Let me talk a little bit about our proposed recruitment process and timeline.
Okay.
Skip ahead 2 slides, please. So I want to just take a quick sidestep and talk a little bit about the policy board and their committee membership work group. So as mentioned, the policy board's been really focused on diversification and recruitment and retention of their committees. There are a lot of committees of the policy board. We are one of them. The new committee will continue to be one of them. And so this is a work group that's been brought together in the last couple of months to put together a process for ensuring diverse and equity-focused committee membership. And so this applies to all committees of the board. This work group will also be providing guidance on best practice for committee recruitment and retention, and providing recommendations for systemic changes that will support diverse and equity-focused committee membership. So on July 13th, there was an informational webinar for the policy board, and that was recorded. I can share the link out that shared some of the work that's been going on with the policy board, the committee membership work group, and a consultant to help start pulling this together. The full or the recommendations coming out of this will be presented at the August policy board meeting next week. So that might be something to tune in for if you're interested. But since this Healthcare Cost Growth Target Advisory Committee will be a new committee of the policy board, we want to make sure that we are aligning our recruitment efforts with these recommendations that are coming out of the committee membership work group to the extent possible. Our timeline is not 100% lined up. We are a little bit ahead of when the board is going to be adopting this formally, but we also know that timing wise, we want to get our recruitment started in August. So we're going to try to align with these principles and their charge and these recommendations, but know that that's still evolving. So next, I want to share an example from the recent Health Information Technology Oversight Council Committee, HITALK. They went through a recent recruitment process, and it really helped inform some of the recommendations that the work group is coming out with. And I want to just highlight a couple things because they're a little bit different from how we've done our committee recruitment, a sort of a business as usual model. So the HITALK staff really started with a pretty broad gap analysis, and they looked to see what expertise was missing on their committee. They looked to see what representation was missing on their committee. And then they did both broad and targeted outreach, which lots of things, including one conversations with potential committee members. And I've copied in a couple of outreach highlights from their work. They reached over 25,000 people via email to let them know about the HITALK recruitment. They worked with over 750 community organizations and directly connected with over 25 individuals to help include their to help get the word out in different ways than we have before for committees of the board. And I'm highlighting this because our committee recruitment process historically has been, we put a form on our website and we maybe email a couple of groups of people and say, this is open. There might be some word of mouth where we say, oh, you should know about this, or some of that spreads, but it has not been as thoughtful or as expansive as this example from HITALK's recent recruitment. So looking to this as an example of what we could do or a direction that we could head for our new committee recruitment. So next slide. As I just mentioned, what we propose to do is both our business as usual, where we'll post and make everything publicly available, and do some direct mailing to all of you. We have a very long list of interested parties who receive updates about the committee. We would let all of them know. But then we also want to do some additional recruitment. So we invite you all to help us with that, and we'll provide more information in August. We also want to incorporate some of this in our provider organization outreach that we talked about earlier in the meeting. So whenever we're talking about the cost growth target program and providing this information, we would also be noting the opportunity to apply to be a committee member. We would do some outreach via the community organizations, modeling again after what HITALK did, and then some targeted outreach if needed for some of those specific areas of expertise or specific industry, non-industry positions if we weren't feeling like we were getting good representation coming in. On the next slide is our proposed timeline. So today you are reviewing the draft charter and the proposed membership. Thank you for that. Next week, we are taking this to the policy board. We have time on their agenda to talk to them about the proposed membership and recruitment plan. If the policy board is good with it next week, then we will open recruitment for the committee next month. We hope to have a preliminary slate of recommended committee members to bring to the policy board in October for their review. Because they have been really focusing on committee diversification, committee representation, we're building in some extra time in case they don't agree or have concerns with our proposed slate, and we need to go back and do a little bit more targeted outreach. So we have some time in November and December to do that and to come back to the policy board for approval. Hopefully we would have an approved committee roster by the end of December and would be able to launch the new committee in January. This is an ideal timeline. It could slip. If it slips a month or two, that's okay, even though we do have a little bit of a buffer. But we really do hope to open recruitment in the next couple of weeks and start getting the word out fairly broadly. And as Jeremy said, we do intend to let all of you know. One of your recommendations back in January was that there should be continuity. So some members of the implementation committee, the current committee, should continue on. So we would certainly invite all of you who are interested in continuing on to apply through the process. You're not, in no way are you ineligible from continuing. All right. Any thoughts, reflections about the recruitment plan? Are there ways that we can make this better? Are there concerns about the timing or the proposed outreach?
Thoughts, anyone? All right,
Sarah.
well, yeah.
Kevin here. Just a question. When Hawk sent out the 25,000 emails requests, what was the return on that? So was that a good strategy that actually made a difference in reaching out to maybe some of those other people in the state that really have a skill set to offer, but often aren't aware of these committees through the regular channels?
I don't know what the return is. I will say what I've heard anecdotally, and Jeremy, you might have more detailed information than I do, that the coordination and the outreach through the community organizations was what really made a difference.
Okay.
The email was just sort of a broad all committees list, and it sort of added up to 25,000 folks once you looked at all the distributions. But it was the working with the regional health equity councils, it was working with the community partners that really made a difference in who applied.
Okay, thank you. That's helpful.
Sarah, is there anything you would want anybody on this committee to do between now and when you decide?
Thank you. Yes, if anyone has feedback on the draft charter or the proposed recruitment, please let me know. You can send me an email or call me. By the end of the week would be the most helpful because we are presenting to the policy board on next Tuesday. And I want to make any last minute changes before then, but your feedback is welcome.
Terrific. Okay, very good. There's a deadline coming up on that, right? You need to know that like very soon.
Yeah, Friday. Michelle, can you jump 2 slides?
Yeah.
Yep.
By Friday. Okay.
Friday.
Very, very good. All right. Okay. Any other comments on this topic? Hearing none, then I think we will move to our public comment. Sarah, do we have anybody on who would want to make a comment? Do we have any written testimony?
We received written testimony from the Hospital Association this morning. I emailed that all out to you. It is also posted on the web page in the meeting materials. I think I saw Rebecca on, but I don't think they were going to provide any verbal comments, just the written.
Very good. Then there's nothing else at this point. Is that correct?
I'm not seeing anything else. Michelle, has anyone pinged you for public comment?
No, I haven't received anything.
Okay, then we're all set.
Okay, well, if that's the case, then why don't we go to our last slide? What are there takeaways for our wrap up here? Sarah, anything you want to leave the group with before we adjourn?
Just the request for feedback on anything that we've talked about today. And Jeremy, I don't know if you have anything else to reflect on.
Nope, nothing for me.
All righty. Well, if that's the case, then I want to thank everybody for their time this afternoon. And I want to remind everybody that our next meeting is, I believe, the end of September. Is it the 29th, Sarah?
Yes.
I think that's right. Yes. Hello. So our next meeting will be on September 29th. For those of you that have any comments about the advisory committee, please be sure to get those to Sarah by Friday. And in the meantime, just want to wish everybody good health and stay safe. And it's easy to stay dry right now. So just stay cool is what I would say. Stay cool in the broadest sense of that word. So any other comments before we adjourn? All right. Well, I want to thank everybody. Have a wonderful week, and we will be in touch soon, I'm sure.
Thank you.
Thank you, everyone.